Why do lactulose and rifaximin specifically help to prevent and treat hepatic encephalopathy, or HE? And why don't we use other common bowel regimens or antibiotics? Well, to better understand why, we need to take a step back and talk about HE and what actually causes it. It's a usually reversible neuropsychiatric syndrome that happens when gut-derived neurotoxins, mostly ammonia, reach the brain. Rather than showing up as a focal neurological deficit, it will usually be some sort of fluctuating attention or executive dysfunction. Ammonia and its metabolites are generated by intestinal nitrogen metabolism from protein breakdown. This usually comes from dietary protein, slough enterocytes, and urea that diffuses from the blood into the gut. It can also come from blood being broken down in the case of GI bleeding. Usually, the liver will convert this ammonia into urea via the urea cycle and prevent it from reaching systemic circulation. However, if ammonia does reach systemic circulation and thus the brain, it's then detoxified by astrocytes into glutamine. This can create osmotic stress, astrocyte swelling, and altered neurotransmission, which leads to the syndrome. This makes it easy to see how the consequences of cirrhosis and liver disease leads to a breakdown in this gut-liver-brain axis. First, the damaged liver can't adequately do its job to clear nitrogenous neurotoxins like ammonia. Second, portal hypertension leads to portosystemic shunts which bypass the liver altogether. So, why lactulose? Lactulose is a non-absorbable disaccharide that gets metabolized by bacteria in the colon. It acidifies the colonic lumen, making diffusible ammonia, or NH3, and shifts it towards ionized ammonium, or NH4+. The ionized ammonium is trapped in the lumen because it can't get through the membrane. Thus, it reduces the amount of ammonia that's absorbed and increases how much is excreted in the stool. Second, it's a cathartic medicine, meaning it leads to stool output via emptying of the entire colon. It's essentially a more potent laxative. As such, lactulose leads to faster transit and higher stool water content. This reduces the time available for the bacterial urease and other nitrogen processing pathways in the gut to actually create and deliver ammonia. It also physically clears nitrogen substrates like dietary protein breakdown products or blood in the case of a GI bleed. Over time, lactulose can also nudge the microbiome towards fewer urease-heavy organisms. However, the most immediate clinical effects of lactulose are the acid trapping and the catharsis. Aggressive dosing is needed with a goal of at least 4 bowel movements a day. This is why the PRN orders are often based on the number of bowel movements rather than a set schedule. Well, what about rifaximin? Rifaximin is a minimally absorbed gut-selective antibiotic. It reduces and functionally reprograms the intestinal bacteria involved in ammonia generation. Patients with HE tend to have expansion of urease-producing inflammation-associated bacteria. Interesting, in patients with liver disease, there's a concept called the oralization of the gut, which means that organisms that originate in the mouth colonize the intestine. Rifaximin has broad activity against gram-positive and gram-negative aerobic and anaerobic organisms. Thus, the drug isn't magically sparing good bacteria, it's hitting the bacteria that are most exposed and most overrepresented in the disease state. So the net shift in the community of bacteria can look like it's targeted. However, the clinical benefit of rifaximin goes beyond reducing bacteria. It also reduces their toxin and inflammation signal. Some modern thinking about HE suggests that it's not just purely driven by neurotoxins created, like ammonia. In susceptible patients, the brain's threshold for these neurotoxins is lower due to systemic inflammation and the effects of endotoxins. Rifaximin is thought to help due to decreasing gut-derived inflammatory mediators. This is why the patients might actually improve with rifaximin even if the ammonia number doesn't actually track with the patient's mental status. So you might be asking yourself, would any antibiotic theoretically work to treat HE? Well, in principle, anything that would meaningfully suppress the gut bacteria that's generating the ammonia could help. Other antibiotics like neomycin or metronidazole were used in the past to do just that. However, in practice, using any antibiotic is not really a good idea for a few different reasons. Antibiotics that are systemically absorbed can lead to other extraluminal toxicities like nephrotoxicity, ototoxicity, or peripheral neuropathy with long-term use. Moreover, if an antibiotic is broad spectrum, it can raise the risk for C. diff or dysbiosis that worsens the gut barrier function. Some gut communities can actually be protective, so if we indiscriminately kill off all the gut flora, it can lead to unpredictable metabolic and inflammatory consequences. What about other more common bowel regimen medications? Polyethylene glycol has been studied as an alternative to lactulose for rapid improvement in overt HE. Some RCTs found that it's actually superior to lactulose in achieving more rapid resolution of HE. Mechanistically, it uses the same washout strategy, but just doesn't employ the ammonia trapping strategy of lactulose. In other words, it can help prevent constipation, but it doesn't acidify the colon. Advantages of polyethylene glycol use include complete removal of stool with little effects on electrolyte levels or volume status. It also has a long history of being studied for aggressive bowel prep for colonoscopies, and the protocols in place are easy for bedside staff to follow. Lactulose might be preferred in patients with hyponatremia, given it will pull water osmotically out of the body. So in sum, lactulose addresses the chemistry of absorption by trapping ionized ammonia in the gut and acidifying the colon, and also leading to more throughput or catharsis. Rifaximin addresses the biology of ammonia production plus the immune signaling. Other antibiotics or laxatives can overlap with pieces of what make these drugs work, but they usually either miss the risk-reward balance or one of the key mechanistic components that make lactulose and rifaximin durable options for preventing and managing HE.